Assalamu alaikum students. So this is the third and last installment of the acid-base physiology lecture series. And in this, we will have another look at the various, the four acid-base disorders that we already had a little talk about in the second lecture of the series. But we'll add some emphasis on the causes. Plus, we look at this new concept of anion gap, which will help us diagnose the causes or narrow down the causes of metabolic acidosis, because it's a big category. So the emphasis now will be more on, in this case, metabolic acidosis. Emphasis will be on anion gap and using anion gap to narrow our search for the cause culprit of the acidosis, metabolic acidosis. And throughout, we'll be talking more on causes, what causes each disorder. And then at the end, we'll talk about two special cases related to alkalosis, metabolic alkalosis. Okay, so we know, we'll start with metabolic acidosis. We know that from the diagnosis lecture, that it's characterized by low plasma pH and a low plasma bicarbonate. As mentioned, we'll look at the causes. We've already done, because I think metabolic acidosis we did quite a bit in the diagnosis lecture. Still, I'll just repeat it briefly here. Diabetic ketoacidosis is one of the most common presentations of metabolic acidosis. It's a complication of diabetes, uncontrolled diabetes. So this is one of the most famous causes of metabolic acidosis. Number two is excessive diarrhea. We know that alkali is lost via feces. So excessive diarrhea will take out alkali and also will disbalance the acid and base balance in the body, leading to acidosis. Bicarbonate will be lost. Chloride will be more in comparison, and hence the body will go into metabolic acidosis. Then the kidney itself can be an issue. It may go into failure or RTA, renal tubular acidosis, in which case the tubular cells are damaged. They cannot excrete your normal acid load and replenish bicarbonate. So this is a big issue with the kidney itself, and hence a significant cause. Compensations we have already done, but this is a more structured approach to the compensations. Remember, there are, under the acute phase, you have the chemical buffers inside the cell and in the ECF. Then you have the respiratory system, and in the long term, we mentioned the kidney. Okay, so the concept here basically is that all three basically are engaged with every acid-base disorder. It's only the amount or the role, the extent of the role that they play, and the timeline that they play it at, that differs. So ICF and ECF buffers will come into play, of course, as soon as there will be acidosis, and then respiration will play a significant compensatory role in addressing the pH change by adjusting its ventilatory rate. It will depress it 1.3 mmHg for each drop in bicarb. 1 milli equivalent per liter drop in bicarb is balanced by depressing the respiration, so that the PCO2, I beg your pardon, I've been saying depressed. It's basically the PCO2 is depressed by increasing the respiratory rate. So your patient of metabolic acidosis will come to you in the ER hyperventilating, so that the PCO2 is decreased. Okay, so be very clear about this. I actually showed a table as well at the end of the second diagnosing acid-base disorder lecture that also has this information in a nice, easy format to learn. And at the end, I could not emphasize this under compensations in that second lecture, is that At the end, you do go to kidney. Although, yes, we know that the problem was kidney itself. It did not handle the bicarb nicely. But still, this is the master place where everything goes for mathematical grade correction. So eventually, kidney has to pull up its socks and address the issue and basically uh, make a bicarbonate, reabsorb it properly, make new bicarbonate, and address the original issue, its job, which it did not do initially because of one thing or the other. Okay, so this is metabolic acidosis with some emphasis on the cause. Now, the problem with metabolic acidosis is twofold. One, it is very common. So you will come across metabolic acidosis more than other acid-base disorders. And the second is the list is long. So what do we do about it? It is a long list. It would be nice if we could categorize it along any lines. So the good thing is, yes, there is a way to do it. So anion gap is one of those concepts which we basically use to extrapolate this whole thing. Remember that this is just a concept. There is no gap. There is no gap in anions or cations. In fact, the sum of cations and the sum of anions are in complete balance in the body. But this is an ingenious way. This is a conceptual framework by which what we do is we basically say that, all right, sodium is the main cation. Okay, so sodium in the cation category, let's say sodium is it, and the unmeasured cations, basically potassium, calcium, magnesium, they are in small amounts and fairly constant. So we can ignore them. All right, and it equals the sum of cations. And on the cation front, we have chloride and bicarbonate as the two main anions, I beg your pardon. On the anion front, we have chloride and bicarbonate as the main anions, while there's a small portion of anions which are unmeasured. Again, they are small and known. They include protein, phosphate, citrate, sulfate, and similar anions. So we don't measure them. We say that, let's say, these are unmeasured anions. Just stay with the program. You'll see how this works out in favor of what we're trying to do. So again, the equation is sodium plus unmeasured cations is equal to chloride and bicarbonate plus those unmeasured anions. Okay, we solve it for unmeasured anions, which, by the way, can be called anion gap. Okay, because this is where the gap is. We have left a gap here. Okay, to extrapolate what we want. So we solve this equation for this. We call it anion gap, and then this is the new equation. Sodium, because this went here, so it will be subtracted from sodium. Sodium minus chloride plus bicarbonate. Okay, so this remains intact. The added brackets are there. My mathematics is a bit rusty, but this bit I know. So you basically subtract the main cation from your anions. This is the anion gap, and the value obviously will come out to be something, because you have not measured this bit here, and you are subtracting this whole thing from this whole thing, while this is not being measured, right? So obviously it will give you some mathematical value, and this is that mathematical value. So 8 to 16 milliequivalents per liter of an anion gap is present normally in all of us. Again, I would repeat for emphasis that it's just a concept. There is no gap. There is no mismatch between cations and anions. It's just that we keep this vague. We keep this a gap, a mysterious gap. We leave it. We of course know what's happening here, but just for mathematical reasoning, we leave it, and we draw up this equation like this, actually generate whatever value of anion gap there is. So it's 8 to 16 milliequivalents per liter, with the rest of everything being known i.e. sodium, chloride, and bicarb, all of them are known. The unknown obviously is 8 to 16 milliequivalents, and this is that anion gap. Okay, this is this portion of the whole scenario. Now, why are we even doing this? So let me just give you a generic scenario. Look, if in this patient, in this person with the normal anion gap of this, you add, this guy takes up an acid or develop a condition in which there is increased uh, acid either ingestion or production inside the body. Okay, what's going to happen? Acid will have its own specific anion, right? So that anion will be added here because bicarbonate and chloride are known. Okay, if it's chloride based, it will be known, and if it's it's based on any of these, it will be known. If there is another anion which has been added to it, the value of this anion gap will change, and that's how we catch the culprit. So in the presence of a low pH and a low bicarb, the diagnosis of metabolic acidosis is arrived at. Further differential diagnosis is look at the anion gap. If the anion gap is increased, the list becomes shorter. However, if the anion gap is the same, you'll be thrown off on this statement, but just hang on, stay with me, I will sort this out. So there are two possibilities: whether your metabolic acidosis patient will have a normal anion gap, or whether this chap will have an increased anion gap. This will draw the long list of metabolic acidosis causes into two: metabolic acidosis with normal anion gap, which is a shorter list, of course, and metabolic acidosis with increased anion gap, which is the second part of this long list. So it's much more manageable to now look at this patient, take the history, do a good examination to narrow down further from either of these shorter lists. Okay, so let's see, scenario one. You have lactic acidosis or diabetic ketoacidosis. Okay, lactic acidosis, the anion would be lactate. Okay, in lactic acidosis, lactic acid basically gets buffered with bicarbonate to form lactate. So lactate will be the anion. In diabetic ketoacidosis, as we've mentioned before, there are keto acids, beta ketobutyrate, and acetoacetic acid. Basically, these are the ones which will be the anions. Okay, what happens to the anion gap? Let's see. Okay, so this scenario has been labeled as normochloremic or normochloremia. What has happened is you have added either lactic or a keto acid to the ECF, right? That bit is clear. Now let's solve the an anion gap equation. It was sodium minus chloride plus bicarb, right? So these anions do not feature here. Okay, only chloride and bicarb feature here. And since they are acids, they will obviously consume your bicarbonate. The bicarbonate goes down, which results in the anion gap increasing above normal. I hope you got this. In this particular case, when you have added certain anions like lactate or keto acids, or in methanol poisoning, you have formic acid forming. In uremia, you have sulfuric or phosphoric or hippuric acid retained due to kidney failure, or salicylate is basically another generic name for aspirin. Somebody has overdosed on aspirin, so salicylate is the anion which causes acidosis. In all of these examples, basically the bicarb would naturally go down, okay, because naturally it's metabolic acidosis, which then raises the it raises the anion gap. So now we say that our metabolic acidosis is of the normochloremic increased anion gap variety. Why do we call it normochloremic? Hang in there. I will let you know in the next slide, inshallah. Okay. For now, I hope this is clear. Okay. Increase anion gap causes of metabolic acidosis. Famous ones are right here on this slide. Okay. Now, what happens in diarrhea? What happens to anion gap in diarrhea? Excessive diarrhea would cause metabolic acidosis, right? Because it's the alkali is lost excessively in the excessive diarrhea. The feces go out, taking along excessive alkali. That basically creates an imbalance between alkali and the stomach acid. So the resultant is basically metabolic acidosis. Now, in diarrhea, this is what happens. Plasma bicarb obviously goes down with it because it's a metabolic disorder. Chloride goes up because of the imbalance between the alkali lost in the intestinal fluids and the comparatively increased HCl present in the stomach. So chloride, now you solve this anion gap equation. Chloride goes up, bicarbonate always will go down because of the metabolic nature of the disorder. Voila, the anion gap comes out to be normal. And that's why we call it hyperchloremic metabolic acidosis, as opposed to, let me go back, as opposed to normochloremic metabolic acidosis. Okay, now you understand. The key also is chloride. Basically, the key is chloride. If chloride is constant, then the anion gap will go up. Naturally, the mind will go to these causes, which are obviously fewer than a horrendously long list of causes. Okay, and if you have the chloride is going up and you have a normal anion gap, then the list is again more manageable. Okay, you have diarrhea, and obviously the condition of the patient and the history will tell you that it's diarrhea. And then there are other interesting scenarios in which you have renal tubular acidosis, and in this you have loss of bicarbonate in the urine, excessive loss of bicarbonate in the urine because the tubular cells are damaged and they're not doing their function of reabsorbing bicarbonate, or there is excessive excretion of hydrogen ion. This is basically balanced. Where did the chloride go? You must be thinking. How come we have hyperchloremia in RTA? Well, for electroneutrality, chloride is reabsorbed by this kidney. Okay, because I'll repeat it: loss of excessive bicarbonate or excretion of excessive hydrogen in the urine, both need to be balanced. Okay, so if you are losing a lot of positive ions, chloride will be basically need to be retained back in the body, and hence you have a hyperchloremia in RTA patients. Okay, the other is excessive ammonium chloride ingestion, and this is a famous type of poisoning, and in this the ammonium bit is basically converted into urea in the liver, while the chloride is what gives rise to increased chloride, hyperchloremia, and hence this metabolic acidosis. Okay, so imagine if you have your patient, his or her, the one who brought her in, the attendant will tell you that look, he or she consumed this bottle, and the bottle would obviously be either labeled or it will smell, or there'll be some evidence of ammonium chloride, and you'll be able to tell by the chemical analysis that this is an acidosis. The bicarbonate is low, and since the bottle might say ammonium chloride, the chloride is up in this patient. You work out your anion gap, it comes out to be normal. You confirm the diagnosis, you give the antidote, and that's that. By the way, ammonium in its conversion to urea in liver consumes a bicarbonate. Okay, so this also adds to the acidosis. The chloride obviously directly adds to the acidosis. So this is that. Anion gap's importance in the differential diagnosis of metabolic acidosis, normochloremic and hypochloremic scenario. Right. Then we move on to the alkalosis side of things. Metabolic alkalosis, we know that increased bicarbonate in the presence of increased pH is the very definition of metabolic alkalosis. What could go wrong resulting in metabolic alkalosis? Well, there may be a over ingestion of antacids, basically, which is alkali, to deal with acid burn or acid reflux disease. Any increased ingestion of antacids may result in this. Then there's the interesting case of hemorrhage, which is ECF volume contraction, and this again is something that I discussed in the diagnosis bit, that diagnosis acid-based lecture. That volume contraction, ECF volume contraction, basically leads to decreased GFR, and when the GFR is decreased, the tubular fluid amount is decreased. When the amount is decreased, the velocity is decreased. Blood carrying its filtered sodium hangs around the PCT longer than it usually should. And so the sodium hydrogen antiport mechanism can work in this scenario more, which it does, taking in more sodium than it usually does and secreting more hydrogen than it normally does. This leads to, and again, the hydrogen is coupled by the bicarbonate reabsorption. If I remember, I'll put a reference here for that lecture. There's a picture of the cell PCT showing all of this going on. The bicarb being reabsorbed, the hydrogen being excreted. All of this basically results in metabolic acidosis, and we call it contraction alkalosis because it is coupled with basically a volume contraction, say in hemorrhage or severe dehydration and so on. Then an even more interesting cause of metabolic alkalosis is volume contraction together with loss of non-volatile acid, basically fixed acid, which is the case in vomiting. In vomiting, you lose gastric HCl and you also lose fluid. Excessive vomiting, it should say excessive vomiting. You lose gastric HCl, which is the fixed acid, and of course there is volume contraction because you have lost a lot of fluid as well. This is so special that we have actually dedicated the next whole slide to it. It's very interesting. Let's deal with it in the next slide, inshallah. So compensation, again, the buffers will be the immediate, the acute ones. The respiration, we've talked about this, that increased pH actually inhibits the respiration, leading to a raise in PCO2 because the respiratory centers have been depressed. The PCO2 is raised to basically counter alkalosis. And this stat is basically how much, it's a quantification of how much PCO2 have you raised for each unit increase of bicarbonate. It's 0.7 mmHg increase in PCO2 for each 1 milliequivalent liter increase in plasma bicarbonate. And right at the end, I put an asterisk here. Increased excretion of bicarbonate is the ultimate solution. When I say solution, I mean accurate solution. Of course, this is a solution. So is this, but these are compensations. This ultimately is the solution. The kidney, which is the master of the pH, is the master of so many other things. This kidney is responsible for bringing things back to dot. All right. Now, in this case, the mind goes obviously to the simpler things first. What is metabolic acidosis? It's increase in plasma bicarbonate, right? So how hard can it be to think that increased excretion of bicarbonate by the kidney really is the solution for every ill here? It is. So basically, in causes where you have simple increase in bicarbonate, such as antacids and this, that, the other, these are simpler causes and have at the end have a simpler role for kidney to do, increase its bicarbonate excretion. However, there are certain issues, certain complications in certain special cases, such as this. So if the metabolic acidosis, alkalosis rather, is accompanied by ECF volume contraction. So vomiting now comes to the front. You have to differentiate vomiting from obviously increased antacid ingestion. That's a clear differentiation. Uh, but when you compare it, vomiting with hemorrhage, that's the closer one, and that's what I'm going to talk about. What's the difference between hemorrhage and vomiting as a cause for metabolic alkalosis? Well, in hemorrhage, you have volume contraction. So ECF volume contraction will be there. But what won't be there is loss of any fixed acid. It's hemorrhage. It has nothing to do with any fixed acid, right? So it's simple ECF volume contraction. Okay. Any other cause is not even volume contraction, like ingestion of some excessive alkali, like an antacid. That's a simple, straightforward, just increase the bicarbonate excretion, and that's that. In hemorrhage, as we'll see, in any scenario where ECF volume contracts, you have a slightly more complication to handle. And when ECF contraction happens to be coupled with loss of a fixed acid, you have a double whammy situation, a double cause of metabolic alkalosis, which basically feeds off each other and quote unquote maintains the metabolic alkalosis. And this is the weird part. This is what weird or interesting, depends on how you see it. So let's solve this out. Vomiting is loss of gastric HCl, excessive vomiting, I should say, in which you have lost fixed acid, and this easily goes into the metabolic alkalosis side of things, right? But at the same time, you're also losing fluid. So ECF volume would contract. Now check this out. Most of this information you should know, except maybe one or two bits here. So just remember, principal cell, alpha integrated cell, angiotensin 2, and aldosterone. All of this we have done in the previous lectures. It just comes together here. So ECF volume contraction basically will trigger angiotensin 2 via the renin-angiotensin aldosterone pathway. Angiotensin 2, amongst other things, the many things that it does, it also basically triggers that sodium hydrogen antiport mechanism at the PCT, which I have mentioned. Okay, it increases it. When it increases it, then sodium is reabsorbed, hydrogen is secreted, bicarbonate is reabsorbed, resulted in basically what he says filtered bicarbonate, increased filtered bicarbonate reabsorption, coupled with, by the way, increased hydrogen secretion. So you're getting rid of hydrogen, you are adding more bicarbonate. Obviously, you're creating metabolic alkalosis. So this is done. Look at the aldosterone. This bit probably you didn't put together. How come? Increased aldosterone increases bicarb secretion. Well, what does aldosterone do? Aldosterone acts on the principal cells and basically reabsorbs sodium, right? Coupled with increased potassium secretion, which is a side show in this whole thing, causing hypokalemia. This is not, we are not concerned about this right now. So basically, the sodium which is reabsorbed, let me say it like this: sodium is removed from the lumen. It's the same thing, right? If you remove the excessive sodium from the lumen, sodium is positively charged. What are you leaving the lumen to be in? More negativity, right? This more negativity will attract the neighboring alpha intercalated cell into giving up their hydrogen. So the hydrogen will feel like it's being magnetically pulled from the lumen, which is the negatively charged lumen. And that's how indirectly increased aldosterone increases hydrogen secretion. And that whole reaction gets increased. So for each hydrogen that is secreted, we know that a new bicarbonate is reabsorbed by the alpha intercalated cell. Again, this new bicarbonate absorption is similar to the effect here. Increased hydrogen secretion, the difference obviously is this is filtered bicarbonate, this is new bicarbonate. Important difference, by the way. Both contribute to metabolic alkalosis. So metabolic alkalosis is happening here, and it also is happening here. This is the double whammy, this is the double trouble with vomiting, and hence it's tricky to treat excessive vomiting induced metabolic alkalosis. That was a special case that we wanted to mention. Now we'll finish off with respiratory acidosis and respiratory alkalosis. Most of the stuff we know already from the second lecture. It's characterized by respiratory acidosis. It's respiratory and it's acidosis. So obviously, since it's respiration, the acid, quote unquote, of respiration is carbon dioxide. So no surprises here that it will be increased in the body. The plasma pH will decrease. It's acidosis. The causes is anything which basically promotes carbon dioxide retention. It can be a drug which suppressed your respiratory system, decreasing the ramp signal, the whole respiration, the physical aspects of the respiration have decreased. Obviously, the carbon dioxide will go up in blood, or there is pulmonary edema, due to which there is impaired gas diffusion across the respiratory membrane. That will also lead to increased carbon dioxide retention. Whatever the cause, basically respiratory acidosis will go up, will be caused by going up of the carbon dioxide. Acute intracellular buffering basically is there, as is usually is. You want basically the plasma, basically you want the kidney, remember the rule of thumb, you want the kidney to come to the rescue. So in the acute phase, in plasma bicarbonate is duly increased for by 1 milliequivalent per liter for every 10 mmHg increase in PCO2. So the increase has been quantified, and the rescue has also been quantified. For each 10 mmHg increase in PCO2, you have 1 milliequivalent per liter increase in plasma bicarbonate in acute respiratory acidosis, as opposed to chronic, in which you have this value basically becomes 3.5. So kidney basically ups its game. It enhances its reabsorptive capacity of the bicarbonate and the formation of new bicarbonate by as compared to 1 to 3.5 milliequivalents per liter for every 10 mmHg rise in PCO2. Together, this along with ammonium excretion also addresses the acidosis in the long term. In the short term, it's only bicarbonate increase. In chronic, it's bicarbonate reabsorption increase plus ammonium excretion. That's that. Alkalosis, again, it's the opposite. It's the decrease of PCO2 in the presence of an increased plasma. What can go wrong? Increased ventilation due to fear, anxiety, or maybe a medication going wrong. It can be psychogenic, so a person can induce coughing, not coughing. Actually, a cough was coming up. The brain plays games sometimes. So hyperventilation is psychogenic, i.e. somebody can induce hyperventilation. We can all do that to the point that PCO2 is decreased so much that the body actually goes into a respiratory alkalosis. Okay. And this, the opposite basically happens. In the acute phase, the plasma bicarbonate is decreased by 2 milliequivalents for every 10 mmHg drop in PCO2. While in the chronic phase, you have basically not just decreased bicarb reabsorption, you also have decreased ammonium excretion. And the bicarb excretion, basically from 2, it has increased to 5. So that's that. If you remember, it's a long shot because you guys are second year students, but in first year in respiration, we spoke about acclimatization, remember? And part of that acclimatization was renal response, renal excretion of excessive bicarbonate to address the respiratory alkalosis that basically gets induced at high altitude, all that discussion. Basically, this is that discussion here as well. Okay, so these are the references. This ends acid-base discussion for now. Thank you very much. Assalamu alaikum wa rahmatullahi wa barakatuh.